Imagine you're experiencing this really intense, deep pelvic pain, and it's especially bad during sex.
Oh, it's awful.
Right. So you finally go to your doctor. You are just desperate for an answer at this point. And they run every scan imaginable. They check all your reproductive organs. They even look at the standard pelvic floor
No,
muscle.
they do the whole workup.
Exactly. And then they sit you down and tell you that you are perfectly healthy. Like everything is totally fine.
I mean, it is an incredibly isolating place to be for a patient. You're left sitting in that sterile room feeling like, this debilitating pain must just be entirely in your head.
Right.
But the reality is actually far more mechanical. The clinical magnifying glass is just, well, it's pointed at the wrong tissue.
Welcome to today's deep dive. Today we are pointing that magnifying glass at the actual culprit. We're investigating a hidden, deeply buried troublemaker called the obturator internus muscle, or the OI.
Yeah, the OI.
And in looking through the research for this deep dive, it is genuinely astonishing how extreme tightness in this one specific hip muscle can completely masquerade as a gynecological issue or, a stubborn bladder infection or even a severe organ problem.
It really is a master of disguise.
So our mission today is to unpack the biomechanics of this. We want to figure out how this muscle dictates whether certain sexual angles are pleasurable or just agonizing, and how it can literally hijack your entire pelvic nerve system.
Yeah. To understand how it pulls off this level of anatomical deception, we really have to look at the incredibly unique real estate this muscle occupies.
Okay, set the scene for us.
So we have a group of muscles in our buttocks known as the deep six hip rotators. Most of them sit pretty predictably on the outside of the pelvis, doing normal hip muscle things.
Right, exactly.
But the obturator internus is sort of the rebel of the group.
It really is. I was looking at the anatomical diagrams and the sources, and honestly, its placement looks almost like a mistake.
It does.
Like, its entire muscle belly originates completely inside the pelvic bowl. It essentially lines the inner walls of your lower pelvis, almost like wallpaper.
That's actually a great visual. It forms the lateral wall of your pelvic cavity.
Yeah.
And because it lives inside that bowl, it is intimately enveloped in a fascial web like a connective tissue network that directly attaches to your levator ani.
Wait, let me stop you there real quick, just to make sure we're defining our terms for everyone listening.
Yeah.
The levator ani is that main hammock of muscles that we usually think of when someone says pelvic floor, correct?
Yes, exactly. That is the core of it. They form the muscular base of your torso. They're what support the bladder, the uterus, the rectum.
Okay, got it.
And the levator ani actually originates, in part, right off the fascia of the obturator internus. So structurally, they're literally married to each other.
Wow.
But the biomechanical quirk of the OOI, the thing that sets the stage for all this pain we're talking about, is how it actually has to leave the pelvis to do its job.
Right, because its main job is to externally rotate your hip. Like if you're standing up and you turn your foot outward like a ballerina, that's your OI working.
Exactly.
It also stabilizes the top of your thigh bone, the femur, right in its socket. But to move the thigh bone, it obviously has to get out of the pelvic bowl.
Which requires an absolute architectural marvel.
Yeah.
To exit the pelvis, the tendon of this muscle passes through a small bony gap called the lesser sciatic notch.
Okay.
And as it exits, it has to make this abrupt, super sharp 90-degree turn right over the bone before it can attach to the top of your femur.
Let's visualize the mechanics of that 90-degree turn for a second, because that seems important. In my head, I'm picturing trying to hoist a really heavy piano up to a second-floor window.
Okay, I like where this is going.
And you're using this thick rope. But instead of running that rope over a nice, smooth, spinning metal pulley, you are just pulling that heavy rope sharply around a stationary, jagged brick corner.
Oh, wow. Yeah, the amount of friction generated right at that corner would just be massive.
Right. The rope would start to fray, the tension right at the bed would be incredibly high, and it just makes the entire pulley system totally vulnerable to breaking down.
That is the perfect biomechanical parallel. Because of that extreme 90-degree angle, the specific spot where the tendon wraps around your pelvic bone, the ischium, wow, it takes an immense amount of compressive force every single day.
But just from normal movement.
Exactly. The body even tries to compensate by forming a little fluid-filled sac, a bursa, just to protect the bone from the constant friction of this muscle sliding over it.
So if that physiological rope gets pulled way too tight and loses its slack, I imagine bad things happen.
It spells total disaster for the pelvis. When this muscle is subjected to mechanical stressors, it becomes hypertonic.
And hypertonic
Meaning the muscle is stuck in a state of extreme chronic tightness and spasm. But paradoxically, it's also incredibly weak.
Oh, weird. So it's tight but weak.
Yeah, it loses its functional elasticity. It transforms from a dynamic, stretchy rubber band into this rigid, tender, shortened cord of tissue.
I was reading about what actually causes that hypertonicity in the first place, and it honestly seems like modern life is practically designed to ruin this specific muscle.
It really is.
Like prolonged sitting on hard surfaces puts direct pressure right near it, poor postural habits, pelvic imbalances, and this one surprised me, even just aggressively overdoing clamshell exercises at the gym without proper form, all of that can force it into that hypertonic state.
Oh, definitely. And once it becomes a rigid cord, it pulls this immense unyielding pressure right at that 90-degree turn.
Mm.
And then it radiates that tension all the way back into the fascial web, pulling directly on the pelvic floor.
Which brings us to a major focus of our deep dive today. If this muscle is already fraying over a 90-degree corner just from, sitting at a desk all day, what happens when you force the hip into extreme angles?
It panics.
The sources highlight this muscle as a highly overlooked culprit in deep dyspareunia, which is the medical term for deep pain during sexual intercourse.
Right.
How exactly does a tight hip muscle turn a sexual experience into agonizing internal pain?
It all comes down to mechanical stretch and the body's protective guarding responses. Think about the physical geometry required for a lot of common sexual positions.
Okay.
You are often asking the hips to go into deep flexion, which is bringing the knees up toward the chest, or deep abduction and external rotation, which basically involves spreading the legs wide.
So you are taking a muscle that is already inflamed, shortened, and panicking,
Yes.
and you are stretching it to its absolute physical limits.
Yes. You are aggressively stretching that hypertonic, irritated rope across that rigid, bony corner. Remember, the muscle's primary job is to externally rotate and stabilize. So when you pull the hip into those deep, vulnerable angles, the muscle feels threatened.
And a muscle that is already locked in a spasm definitely does not want to be stretched.
It absolutely refuses. It panics and triggers this reflex to guard itself. It seizes up even further to prevent what it perceives as an impending tear.
Wow.
But here's the really insidious part that confuses so many doctors. The patient doesn't necessarily feel the pain in the side of their hip or their buttocks.
Wait, really? Oh, is that because of that shared fascial web you mentioned earlier?
Yes, exactly. Because the OI shares a direct fascial wall with the levator ani inside the pelvic bowl, it triggers a really powerful phenomenon known as referred pain.
Ah.
The myofascial trigger points those angry knots in the obturator internus. They refer their pain signals deep into the vaginal canal, the rectum, the tailbone, and the groin.
Let's unpack the mechanics of that referred pain for a second, because the neurology of it is honestly fascinating. The brain essentially misinterprets the origin of the distress signal, right?
Pretty much,
So,
yeah.
like the signals from the hip muscle and the signals from the vaginal canal or the pelvic organs, they all travel along very similar nerve pathways to the spinal cord.
They converge. So when the spinal cord sends that alert up to the sensory cortex in the brain gets totally confused. The person feels a deep, aching, burning, or pressure sensation internally during penetration.
Oh, man.
So naturally, the brain and the patient and the doctor assumes there is a severe gynecological or organ problem.
Which perfectly explains that tragic scenario we started the show with. The doctor runs the MRI, they do the ultrasounds, and the organs are pristine. They're fine. It's the muscular suspension system holding the organs that is actually screaming.
Exactly. This is why deep pelvic pain can persist even after incredible invasive medical interventions.
What do you mean, like surgeries?
Yeah, a patient might be suffering from severe endometriosis, which is a very real, incredibly painful disease.
Right.
They undergo expert excision surgery. The surgeon meticulously removes all the diseased tissue. The organs heal beautifully. But then the patient tries to have intercourse 6 months later, and that deep, stabbing pain is still there.
Because the obturator internus doesn't know the surgery happened.
Exactly.
It is still locked in that hypertonic guarding pattern. It spent years bracing against the pain of the endometriosis, and now it's just stuck in the on position.
The muscle essentially took on a life of its own. The fascia tightened, the trigger points solidified, and until someone physically addresses that specific 90-degree hip muscle, that deep referred pain during those hip-flexed sexual angles will remain.
That is genuinely mind-blowing to think you could have an organ removed or operated on, but the hip muscle just keeps broadcasting the ghost of that pain.
It's tragic, honestly.
It is. And as we dig further into these sources, there is this whole other layer of deception involving the nervous system, the nerve trap.
Yes. This is where a musculoskeletal problem morphs into a severe neurological one.
Yep.
We need to talk about a very specific anatomical structure called Alcock's canal.
Alcock's Canal, I kept seeing that in the literature. It sounds like a geographical feature, or I don't know, a shipping route.
Well, it essentially is a vital shipping route within your pelvis. Alcock's canal is a fascial tunnel. But what's crucial to understand here is that it's not a tunnel made of hard bone. The walls of this tunnel are actually formed by the fascia of the obturator internus muscle itself.
Wait, so the connective tissue of this exact muscle we've been talking about literally creates the tunnel walls?
It does, and passing right through that specific tunnel is arguably the most important nerve in your entire pelvic region, the pudendal nerve.
I was reading through the clinical notes provided on the pudendal nerve, and it sounds like the master control switch for the entire pelvic floor. It's a mixed nerve, meaning it handles both sensory data and motor commands, right?
That's absolutely correct. It has a massive amount of responsibility.
Mm.
On the sensory side, it's responsible for providing feeling to the genitals, the perineum, and the anus.
Okay.
And then on the motor side, it manages the voluntary control of your urinary and anal sphincters. It is the literal nerve that allows you to consciously hold your urine when your bladder is full.
So if I'm visualizing this right,
Yeah.
we have a master control cable running through a tunnel, and the walls of that tunnel are made of a hip muscle.
Yep.
What happens when the obturator internus becomes hypertonic from all that sitting or mechanical stress?
The muscle bulks up with spasm. It thickens. The fascia surrounding it becomes incredibly rigid and tight.
It's going to physically crush the tunnel, like it's compressing Alcock's canal.
It acts like a vice grip on the pudendal nerve. This results in a condition called pudendal neuralgia. And let me tell you, nerve pain feels entirely different from a pulled muscle.
Yeah, muscle pain is usually an ache or like a soreness, but the sources describe nerve pain as angry.
Very angry. It manifests as burning, zinging, electrical stabbing sensations, or even rawness and total genital numbness. But perhaps the most maddening symptom of all is the urinary deception.
The fake UTI.
Yes. Patients often describe feeling like they have a severe, persistent urinary tract infection. They experience intense burning with urination, extreme urinary urgency, or just a constant feeling of bladder fullness.
And so they go to the urgent care clinic. They provide a urine sample. I mean, they do a urine sample.
And the culture comes back completely clear. No bacteria, no infection.
That has to make people feel like they are just losing their minds. I mean, they are feeling the visceral reality of a bladder infection, but the bladder is totally fine.
Yeah.
It is actually a hypertonic hip muscle strangling a nerve that talks to the bladder sphincter.
Yeah.
The nerve is inflamed, so it's misfiring distress signals that the brain misreads as a UTI.
Or, they experience severe radiating pain simply when they sit down. Because when you sit, you are putting mechanical pressure near your sit bones, directly onto an already compressed, inflamed pudendal nerve.
So sitting at a desk for work.
Or driving a car, it becomes pure, unadulterated agony.
This raises a really important practical question. If someone has these symptoms, let's say they have the urinary urgency or that deep internal pain during sex, the standard advice you always hear in the fitness world is, oh, you need a stronger pelvic floor. Go do 100 Kegels.
Oh, no.
Or if their hip hurts, a trainer might say you need to stretch your hips aggressively to loosen them up. If the muscle is already tight and crushing this nerve, wouldn't doing Kegels or deep stretches actually pour gasoline on the fire?
That standard advice can be absolutely disastrous in this specific scenario.
Wow, really?
Let's break down the mechanics of a Kegel. A Kegel is a concentric contraction, meaning it actively shortens, flexes, and squeezes the muscle fibers inward.
Okay.
If the obturator internus and the levator ani are already hypertonic, meaning they are chronically contracted, exhausted, and locked in a spasm, asking them to contract harder with a Kegel is like asking someone who is having a severe locking calf cramp to do heavy calf raises.
Ouch. Yeah, you would just tear the tissue or make the cramp lock up way worse.
Exactly. It further shortens and irritates the tissue. It clamps down on the pudendal nerve even harder, increasing that burning sensation.
And what about stretching?
As for aggressive stretching, bring it back to your rope and pulley analogy. If that rope is already frayed and under immense tension around that rigid 90-degree corner, aggressively yanking on the ends by forcing the hip into a deep, forced stretch isn't going to magically relax it.
It's going to trigger that stretch reflex you mentioned earlier. The muscle is going to spasm even tighter to prevent you from snapping it.
Right. It creates a vicious cycle of guarding. The harder you stretch it, the tighter it gets.
So what does this all mean for someone suffering from this? If they can't Kegel their way out of it and they can't stretch it out like a normal tight hamstring, how do we actually solve the puzzle? Like, how do you even confirm this invisible deep-seated muscle is the actual problem?
Well, this is where the expertise of a specialized pelvic floor physical therapist becomes absolutely critical. They're uniquely trained to look past the superficial organs and evaluate the muscular architecture inside the pelvis.
Walk me through that diagnostic process, because as we established, this muscle lives inside the pelvic bowl. How does a therapist even reach it to test it?
They conduct an internal pelvic exam, accessing the musculature either transvaginally or transrectally. The therapist will insert a gloved, lubricated finger and basically trace the lateral wall of the pelvis. To find the obturator internus, they generally orient to a 3 o'clock or 9 o'clock position internally, usually just past the second knuckle.
That is incredibly specific mapping.
It has to be precise. And to confirm they are actually on the right muscle, they'll perform an external mechanical test simultaneously.
How does that work?
While their finger is resting on the muscle internally, they will place their other hand on the outside of the patient's knee. And then they'll ask the patient to gently push their knee outward against the therapist's resistance.
Ah, I see. Because pushing the knee outward engages that external rotation, which is the primary job of the OI.
Exactly. When the patient pushes, the therapist will feel the obturator internus actively contract right under their internal finger.
Wow, that's clever.
And if applying gentle pressure to that specific muscle reproduces the patient's familiar deep pelvic pain, or sends a zinging sensation down the pudendal nerve path, or refers pain to the exact spot in the vagina that hurts during intercourse, well, they've found the culprit.
That moment has to be incredibly validating for a patient. I mean, to finally have someone touch a physical spot and say, is this the pain? After years of clear MRI scans and negative UTI tests.
It's often deeply emotional. Validation is really the very first step in healing a sensitized nervous system. And once it's accurately diagnosed, the treatment protocol is all about conservative, gentle downtraining. We want to coax the nervous system into letting go of this muscle rather than forcing it.
I was trying to picture the treatment protocol based on the reading, and it sounds a bit like dealing with a hopelessly tangled, super delicate gold necklace.
Oh, that's a great way to think about it. If you have a knot and a thin gold chain.
You absolutely cannot pull on both ends.
No.
If you just yank the chain, which would be the equivalent of that aggressive hamstring stretch.
You make the knot impossibly tight, the friction locks it in place.
Right. So to fix the necklace, you have to sort of roll it between your fingers. You have to feed slack into the system, gently massaging the tension out so the knot can loosen itself.
That is the exact biomechanical goal of the treatment. No yanking. Treatment involves gentle myofascial release. The therapist might maintain steady, light pressure on the trigger points internally until the tissue slowly melts and releases its holding pattern.
That makes sense.
They might also use techniques like dry needling externally in the glute to release the tension at the muscle belly. And crucially, they teach the patient neuromuscular re-education.
What does that neuromuscular work look like for the patient at home? Like, how do they keep it from just locking right back up?
It involves somatic releases. For example, instead of a deep, aggressive hip stretch, a patient might lie comfortably on their back, place a soft massage ball under their glute, just slightly medial to the sit bone, and perform very slow, gentle windshield wiper motions with their knee.
Creating slack in the system.
Yes, creating slack in the fascial web. You're decompressing Alcock's canal. You're giving the pudendal nerve room to breathe and heal. And as that chronic tension normalizes, the referred pain during deep sexual penetration diminishes.
And the fake UTI symptoms.
They fade away, and normal hip mechanics are finally restored.
It is wildly interconnected. Let's recap the major mechanics of this for you listening, because we've covered some really dense anatomical ground today.
We definitely have.
So the obturator internus is this sneaky, deep hip rotator that lives inside your pelvis. Because it takes a sharp 90-degree turn over your pelvic bone like a rope over a jagged corner, it is highly prone to becoming hypertonic, meaning it gets rigid, tight, and exhausted from daily stressors like sitting or poor posture.
And that extreme tightness is a major, yet often totally ignored, culprit in deep referred pain. especially during sexual angles that force the hip into deep flexion and rotation, aggressively stretching that angry muscle.
Furthermore, its fascia forms the walls of Alcock's canal, meaning a tight OI can literally strangle your pudendal nerve. That nerve compression mimics a UTI, causes intense genital burning, or just makes sitting unbearable.
Right.
But the good news is it can be diagnosed with a specialized internal exam and treated with gentle, targeted release, not aggressive Kegels.
Which brings us to a much larger physiological concept that the research points to, one that extends far beyond just the pelvis.
Yes, and I really want to leave you with a final provocative thought to mull over based on the clinical sources we dug into today. We spent a lot of time talking about how this one hidden muscle can trigger referred pain, how it can physically squeeze a nerve, and how it can trick your brain into thinking you have a failing organ or a chronic infection.
Yeah.
But what happens when that deceptive distress signal is broadcast to your brain nonstop for months or even years?
Well, the nervous system adapts to it. We see a phenomenon called central sensitization.
Let's look at the mechanics of central sensitization. If a single tight hip muscle essentially tricks the central nervous system for long enough, the nervous system itself actually begins to change physically.
Yeah, your spinal cord and your brain become hyperreactive.
The internal alarm system gets stuck in the on position. The threshold for what constitutes pain drops so low that even normal sensations like a full bladder or light touch or normal digestion are interpreted by the brain as intense, dangerous pain.
The hardware of the nervous system becomes sensitized. So the symptom is no longer just the tight muscle. The symptom becomes the hypersensitive alarm system itself.
Exactly. So my question for you is this. If a hidden mechanical knot in a hip muscle can perfectly mimic a bladder infection, ruin sexual function, and literally rewrite how your brain processes pain,
Mhm.
how much of our daily physical suffering is simply the brain misinterpreting distress signals from our interconnected fascial web?
That's a huge question.
It is. Challenge yourself to view your body not as a collection of isolated, independent parts like a car where the engine and the tires break down separately, but as an intricately wired, beautifully complex suspension system. A system where pulling on a thread in the hip can unravel a nerve in the bladder. It really makes you rethink how we view chronic pain, because more often than not, the symptom you feel is rarely the true source.